Septal defects are divided into three groups. A hole in the middle of the interatrial septum. This is called a septum secundum defect. Those of you who didn't like embryology, now is the time to go back and understand why there's a septum primum and a septum secundum. If the hole is close to the heart, we talk about a septum primum defect. And then there's a third category in which the holes are close to the vena cava, and these are called sinus venosus defect. And then that's something that we see very commonly. So the most important here is the secundum and the primum defect. Now, interseptal defect are rather common anomalies, but I bet very few of you have ever detected one because they are hard to detect, and so we tend to miss them. They are associated with many other cardiac lesions: ventricoseptal defect, pulmonary stenosis, and many complex defects resulting in interatrial shunts. Another common one is Holter-Remsen syndrome. If the mother of the baby has a missing finger, missing thumb, or she has a triphalangeal thumb, think that the baby has also Holter-Remsen syndrome. So the finding in the four-chamber view is if you have an osteoprimum defect, you have missing the crux between, you're missing the segment between the crux of the heart and the foramen ovale, and I'll show this to you in some images. If you have a septum secundum, this is much more tricky because they are located at the level of the foramen ovale. So they are actually the foramen ovale, which is a bit too large. So the big clue here is you're missing the foramen ovale flap. Remember when we looked at the four-chamber yesterday, I told you, look at the motion of the foramen ovale flap and make sure that it's present. Now, this is the type that we see in most common, the ostium secundum, when you have a very large form. When you don't see any interatrial septum, this is typically a ostium secundum, and the sinus venosus are rare and we don't really see them very often. So here we have a four-chamber, and there's a big communication between the right and the left, same thing over here, same thing over here. This is the complete form of ostium secundum, and when you put color Doppler, you can see continuity of the Doppler signal between the two. This is a segment here in the normal heart which is missing in the ostium primum defect. So in ostium primum you will see this section of the interatrial septum, but you will not see this section here. So here's a large communication between the two atria. This is a baby that has a partial trisomy 10p and a partial monosomy 4p, but you could have something similar in baby that have trisomy 21. So large communication between the two atria. Now we move on to the ventricoseptal defect, and the ventricoseptal defect are typically classified into four different groups. You may have a membranous septal defect, or you can have a trabecular or muscular septal defect. These are the ones that we see the most commonly. You can have an inlet defect, or you can have an outlet defect. And it's not always easy to recognize the difference between an outlet defect, a membranous ventricoseptal defect, and an inlet defect. So you may have some hesitation and you may kind of mix them together, but you can recognize them easily from the trabecular or muscular septal defect. Now, ventricoseptal defects are extremely common, so they're essentially associated with everything else. So they are not the kind of thing in which you always say, I have ventricoseptal defects, so what else should I be looking? You should be looking at the entire baby, not only the heart, but the rest of the baby, because they have association with aneuploidy. So here's an inlet defect. You see a gap over here. You see the communication between the left ventricle and the right ventricle. This is a very large defect. Here you have the same thing, and you also notice that the AV valve are at the same level. So you have a large inlet defect at this level. Now we're moving into the muscular defect, and this is a very large muscular defect here. Usually they're not so big, and usually they're not as visible on the grayscale image. You have to use color in order to see them. And this is an example in color. You can see the interatrial septum here, and there is a flash of color at the end. I'm going to replay this clip, and notice that when you don't have the color, it's almost impossible to see this defect. There's a tiny defect, but it's much better to see with color. So I want to urge you that every time you do a four-chamber, you have to put color if your machine has it. You paid a lot of money to get this color button on your keyboard. Use it, okay? So look for that. Other example, if anyone can see the defect here, you are much better than me. I don't see the defect. Let me replay the color clip here, and you see the defect here. What is the color of the flow in the defect? Is it blue or is it red? It's blue and red. What does that mean? It means it's bidirectional. Ventricular septal defect in the child are always unidirectional. They go from the left ventricle to the right ventricle. In the fetus, that's not true. They go from the left ventricle to the right ventricle during systole, but they go from the right ventricle to the left ventricle during diastole. So fundamentally for the fetus, it really doesn't matter they have ventricular septal defect. So you're not going to see that this baby is floppy or has high drops because of ventricular septal defect. You have to really look at the anatomy. Another example here, you can see blue in one direction, red in the other direction, and you can see that in grayscale, there's just a little line here which will be very easy to be missing. So be careful about this. Another example, you can see the jet over here quite clearly, and if you don't have the color at the proper time, you may easily be missing it. So in practice, what you do the 4-chamber, you adjust the color Doppler, and then you get a little clip, and then you go frame by frame for at least 1 or 2 cardiac cycles. You don't have to have 20 cycles, this is too tedious. If you have 2 or 3 cardiac cycles and you see the defect in the same portion of the cycle at each time, you have made the diagnosis. Some people are very obsessive and they even try to get a pulse wave Doppler in the defect. That is too time consuming and we don't have the time to do this. Here's a perimembranous septal defect at this level. Here's another one. And you see this is very similar to the inlet defect that I showed you before. And here, many other ventricular septal defects. Okay, so a rather common type of anomaly. Here we have one just under the aorta, subaortic defect, the kind of thing you can see in babies that have tetralogy node. Here's another one. You can see the left outflow tract. This is in blue. And under the blue, you see this little red jet, which is just coming over here. And so you have a defect just under the aorta. So subaortic defect. Now I'll show you this pitfall here, so I'm going to skip that. So prognosis and management, usually they are asymptomatic in the neonatal period. A great majority of them will actually spontaneously close. So it's kind of good because if you miss it and the baby doesn't come with a VSD, no one is ever going to blame you for that. But you want to also rule out associated anomaly, in particularly aneuploidies, and if there is none, then you use the standard obstetric management. And now we move to the combined atrial and ventricular septal defect. These used to be called endocardial Cushing defect, and they're also called atrioventricular canal, but the preferred terminology is now atrioventricular septal defect. And they're divided into 2 groups, an incomplete form in which there is tethering of the valve over the crest of the septum, and this allows to have all sorts of atrial to atrial, atrial to ventricle, and ventricle to ventricle communication. And then there's a complete form in which there is nothing in the middle of the heart, and this can be further subdivided, and I'll show you later. And then we have 1 large anterior leaflet and 1 large posterior leaflet. If we compare the basal view of the heart with the aortic valve here, the mitral, the tricuspid valve, in the incomplete form, we may have clefting of the mitral valve, which is very difficult to see prenatally, and you have this abnormal shape of the tricuspid valve, and they are at the same level. This is what is important in the 4-chamber view. This 2 AV valve will be at the same level instead of having the tricuspid, which is closer to the apex. Now, in the complete form, you have several leaflets, but 2 predominant leaflets. You have the superior bridging leaflet and the inferior bridging leaflet, which is over here. And so when you have diastole, the 2 leaflets will be away from each other, and you have a big open gap in the middle of the heart. So the complete form has been subdivided into an A, B, and C form. This is a massive classification. In the type A, you have an anterior leaflet that is divided in two equal parts. There's a cleft in between here, and they have papillary muscle attachment to the tricuspid side of the heart, so the right side. And this is typically associated with babies that have left-sided obstruction. In the type B, which is much more uncommon, you have a papillary muscle, the remnant of the septal papillary muscle of the tricuspid valve, that has a corded tendon that attached to both parts of the leaflet. And then in the type C, you have no attachment whatsoever. So you can see a leaflet and no corded tendon going to the interventricular septum, and this is the one that is associated with the tetralogy of PHILLIP. So here we have a large septal, large leaflet. You see it's attached here on the side of the septum. This is the complete form in a baby who has trisomy 21. So you find atrioventricular septal defect, the complete form. The predominant thinking you have is with trisomy 21. Here's a younger baby, also trisomy 21, 14 week. You see the big gap at the septum, and you see this large floppy valve that is bridging over the two ventricles. Now, what are the findings in the four-chamber view? In the complete form, you have this bridging AV valve. You have a shortened interventricular septum, and you see here the corded tendon going onto the right side of the septum. So this is arrested classification type A. In the baby here, sorry, I think I'm missing something here. Okay, here we have the big AV valve. You can see that the ostium secundum is present. The ostium primum is missing. We have a defect below the foramen ovale to the crux of the heart. We still see the foramen ovale flap. So we have ostium primum defect, which is the one associated with the atrioventricular septal defect. We have a ventricular septal defect on the other side, and we have a large bridging AV valve over the two ventricles. Another example over here, you can see a large common atrium, you can see a large interventricular septal defect, and you see the membrane, you see the anterior leaflet, which is attached here to the right side and the apex of the septum. Again, arrested type A. In the four-chamber, for the incomplete form, this is a bit more difficult to recognize, because if you don't pay attention to the position of the tricuspid and the AV valve, you're missing the big criteria. So that is the important thing to recognize, that the two AV valves are attached to the same level instead of having an offset between the two. Now, if you're really good and you have a baby that is very cooperating, you can see the cleft of the mitral valve, but I've never seen an example of that. So here we go into the four-chamber. You can see this big bridging gap on both sides, and you see the classical image of this inflow that looks like a Y into the two ventricles at the same time. You see this during diastole, flow enters from both atria to both ventricles at the same time with this division at this level. Another example, you can see this big bridging valve. You can see still part of the foramen ovale flap, where you almost don't see the interatrial foramen anymore. And you can see during diastole with car Doppler that blood is going into both ventricles at the same time. So that makes the diagnosis quite easy. This is an early fetus. You can see the baby also has an important finding, is the heart rate is too slow. Babies that have atrioventricular septal defect are missing portion of the septum on which the atrioventricular septal node, the atrial node is, and so they have conduction delay and they have a slow heartbeat. You see the crest of the septum. Remember I told you yesterday to look for this white echo that tells you that this is not a dropout artifact, and you see the big valve that is opening over both ventricles. Another example here, you see the bottom of the septum primum over here, and you see the gap in between right ventricle, left ventricle, and the over valve. Another example here, you see big defect Same thing all the time. So it's easy to recognize there's nothing doing diastole. So this is the complete form. And if you have any doubt, you do coil Doppler and you see the inflow into two ventricles that are merged in the middle of the heart. Now this is a bit more difficult. You could be looking at this and say, oh, this is a normal four-chamber, apex and descending aorta on the same side. But if you look carefully, you see that those two AV valves are at the exact same level. Okay, so this is a very important finding to look at. If you see the two AV valves at the same level, this is not a normal heart. This is a baby that has the incomplete form of atrial ventricular septal defect. On the clip on the right side here, you can also see two AV valves at the same level. This is a much younger fetus, I think about 12, 14 weeks, and you don't see very much in this heart, but you can see it has this irregular bradycardic rate. You do transvaginal, and you can see the interruption of the interventricular septum and the bridging AV valve over the two ventricles. So you've made the diagnosis of atrial ventricular septal defect. It's first trimester baby. This baby has trisomy 21 until proven otherwise. Now, sometimes you can make the diagnosis not by even looking at the heart. This is a regurgitation in the right atrium and the inferior vena cava. And what you see on this side of the tracing is the ventricular rhythm. On this side, you see the atrial rhythm. And you can see clearly that the atrial rhythm is regular, but the ventricular rhythm is very irregular. And more than that, the atrial and the ventricular rhythm are not correlated. There's a complete atrioventricular block between one and the other. And not only that, but you can see that when some very big ventricular contraction, you interrupt the atrial flow, so you have a large amount of regurgitation. So even from this simple image, you can deduct that the baby has the complete form and therefore most likely trisomy 21. The differential diagnosis is with the univentricular heart, and the partial form. You can also think about the persistence of the left supine cava with dilatation of the coronary sinus. So what are the associated anomaly? Multiple cardiac anomaly. Tachycardia, bradycardia mostly, hydrops because the heart is pumping inefficiently. And then you have a whole bunch of other anomalies that are essentially anomalies related to the aneuploidies. Atrioventricular septal defect being related to aneuploidy, trisomy 18 and 21. All these associated anomalies, diaphragm hernia, duodenal atresia, omphalocele will be associated with atrioventricular septal defect. And then also isomeres will have some atrioventricular septal defect. Prognosis and management, very poor prognosis. The prenatal mortality is 14 to 22%, and the postnatal outcome depend on whether there is some associated anomaly or not. So what you want to do is make sure that it's an isolated finding with nothing else affecting the fetus. Check for development of a heart failure, because a baby that has an atrioventricular septal defect and a heart failure almost always die. And otherwise you do the standard obstetrical management. So to summarize that, atrial septal defect, two big forms. Ostium primum, you're missing the segment between the foramen ovale flap and the crux of the heart. Ostium secundum, you're missing the foramen ovale flap. For the ventricular septal defect, four forms. All the inlet, outlet, and membranous are easy to confuse, but they're easy to differentiate from the muscular or trabecular form. Always do coil Doppler to see the transfer of the blood during systole and diastole. And then the atrioventricular septal defect, the big clue is make sure that the two valves are at the same level. This is the incomplete form. And if you don't see anything in the middle of the heart, the baby has the complete form. So this one I had to show you for the septal defect. And I'm going to save time by going directly into the venotruncal anomaly. And Kim Lowen is going to talk to you about the D transposition and the L transposition. And so I'm going to talk to you mostly about tetralogy of Fallot. And during the rest of the time that I have, I'd like to show you some of the heterotaxy, because we've been talking about heterotaxy yesterday. And I also want to show you some of the venous anomaly, because I have mentioned to you the anomalous pulmonary venous return and the persistent left superior KHOA. So let's go back into the goniotruncal anomaly, and let me show you about the tetralogy of PHILLIP. This is PHILLIP, who was a French physician, and he's actually not the one who described that originally. It was called the blue disease before his description, but he crystallized all the findings, and since then the description has been associated with his name. Now, if you compare to the normal heart, in tetralogy of PHILLIP you have one single problem, which is the malalignment of the infundibulous septum and the muscular portion. So these two segments here did not align properly, and this caused three problems. First, there's a gap in between, so you have a ventricoseptal defect. There's an overriding of the aorta, and there's a restriction to the pulmonary inflow. So this tetralogy of PHILLIP is a combination of a sub-aortic ventricoseptal defect, an aortic valve overriding the defect, an infundibulary pulmonary stenosis, and hypertrophy of the right ventricle, which is not something we see prenatally. This is something that is a postnatal finding. So this is a rather common disorder. 5 to 7% of all congenital heart disease are tetralogy of PHILLIP. So you will see some if you do any kind of number of scans, and it's associated with extra cardiac anomaly in a good proportion of the cases. Vectoral anomaly, if you see a baby that has a spine that has a curve in the spine, a hemivertebra, remember this is the VA, vertebral anomaly, and the C is cardiac anomaly, so tetralogy of PHILLIP, so associate these together. You can also have gastrointestinal anomaly, central nervous system skeletal anomaly. Look for trisomy 21, 18, and then the microdeletion 22q11. So multiple things to think about. Now, sometimes you can have other cardiac anomaly, including an atrial septal defect, that is called a pathology of cartel, atrial ventricoseptal defect, the one we just looked at a second ago, atrial ventricular block, persistent left superior KHOA, ectopia cordis, anomalies of segmentation of the aorta, like coarctation or tubular narrowing, or absence of the pulmonary valve or pulmonary artery, which is actually a form of tetralogy in itself. So the tetralogy that I'm showing here is the classical tetralogy. 85% of tetralogy of PHILLIP will present like that. Now, 13% of them, you will have a further progression in which the pulmonary hypoplasia becomes a pulmonary atresia, and at that time there will be no further forward flow in the pulmonary artery, and you will have pulmonary atresia. This is called the critical tetralogy of PHILLIP. Now, don't be disappointed if you do an 18-week exam and you make this nice diagnosis of tetralogy of PHILLIP, and when the baby is born, he does not have tetralogy of PHILLIP. Instead, it has pulmonary atresia with ventricoseptal defect. Well, you didn't make a mistake. This is just a normal evolution of the disease. The tetralogy of PHILLIP has evolved into the pulmonary atresia with ventricoseptal defect. And then less commonly, you will have an absent pulmonary valve, and I'll show you the difference when we have finished this segment here. So what's abnormal in this 4-chamber view here? I want to hear two findings. How about the axis of the heart? Is the axis of the heart normal? Remember, it should be 45 degrees to the anterior posterior line. This is almost 80 degrees. Okay, so the baby has left axis deviation. What else is abnormal? Yeah, the descending aorta is not descending on the left side. This descending aorta is descending on the right side, okay? Very important. Left axis deviation and right descending aorta, this is a goniotruncal anomaly until proven otherwise. Now, do you see a ventricoseptal defect? Not always. The ventricoseptal defect is easier to see when you go into the left outflow tract. So here, look for the interventricular septum angle and look for a right descending aorta. Now, here we have a 4-chamber that looks quite normal. We don't see the septal defect very well, and you have to really go into the outflow tract view and the 3-vessel view. And when you get into the 3-vessel view, what you typically see is a large aorta with a thin pulmonary next to it. You see, remember the line I showed you yesterday that goes from the front of the pulmonary to the supravena cava? That line should be in front of the aorta. Here, the aorta is in front of the line, so we have a thin pulmonary and a large aorta. Here in the outflow tract, what you see very typically is the break in the ballerina foot. Remember I showed you the ballerina foot yesterday? You see clearly the leg of this ballerina is not going to this foot. This leg here is aiming at the interventricular septum, and you can see a white dot here at the crest of the septum. So we have an overriding aorta, and this aortic valve is above both ventricles. Now there's some subtle thing here, because if the aortic valve is overriding the septum by 50%, it's called tetralogy valve. If it's overridden by 51%, a bit more to the right side, it's fundamentally the same physiology, but now it changed name. It's called double outlet right ventricle. So be aware of that, so that when you diagnose tetralogy valve, think to see what the overriding is, because it could actually be double outlet right ventricle. But these are technical detail. Fundamentally, you have made the correct diagnosis, and you see both ventricle emptying in the aorta at this level. Here you can see also the aorta overriding both ventricle, and here same thing. This aorta is in front of the interventricular septum, and you see the right ventricle and the left ventricle. Now, one of the big rules of fetal echo is that you can use a lot of reasoning, so you don't have to memorize everything. Think these are rivers. If you have two rivers that are joining together, you get a bigger river. Okay, that is simple. If you have the flow of the left ventricle and the flow of the right ventricle going to the aorta, what will happen to the aorta? It will enlarge. If the aorta enlarges, what happens to the aortic valve? It enlarges also. If the aortic valve enlarges too much, what becomes of the leaflet? They become incompetent. So this is something to keep in mind, is that if you have too much flow through the aorta, the leaflet are going to be distended, and now you're going to have aortic insufficiency on top of the tetralogy valve. And remember what I told you yesterday, dilatation of the fetal heart depends on regurgitation more than it depends on obstruction. So if you see an aorta, like in this image on the right side, an aorta which is bigger in diameter than either of the ventricle, you know that this aorta has an aortic valve which is insufficient. And so this is going to complicate the management of this baby. So here we have overriding of the aorta, overriding, overriding. This is called the lobster claw syndrome. You can see the two like a claw of a lobster. With color Doppler, nothing very different. You see this Y-shaped color image here. Remember, I just showed you a Y-shaped color image, but it was doing diastole in the atrioventricular septal defect, a complete form. Now this is doing systole. This is a blue one instead of being a red one like we saw in the previous anomaly. Now, in the aorta, the Doppler will show some high velocity. What is the maximum velocity in the aorta? Anyone brave? It's 1 meter per second. Aorta, pulmonary, and ductus, all 1 meter per second. So up to 100 centimeter, here we're fine. Here, what you see in the three-vessel view is very typical. You see an aorta that is larger than the pulmonary, and you see an aorta that is bulging in front of the line between the pulmonary and the supravena cava. This is a good trick. And remember, when you do the three-vessel view, look to see there where the thymus is present. If the thymus is not present, you have the DiGeorge syndrome and the microdeletion 22q11. So you can also do the short axis view to compare the size of the aorta to the pulmonary, and in tetralogy valve you will see a larger aorta and a smaller pulmonary. This is another three-vessel view, an aorta which is massively larger than the pulmonary. And when you see that, you want to do cardiopathy, because you want to see whether the flow in the pulmonary is forward or whether it's retrograde. Okay, so important to see for the prognosis and the management of this baby. So there's an echogenic focus here. Don't look at that. Look at the overriding, and you see the overriding over here. Same thing here, overriding and overriding over here. So very simple to recognize. Another baby trisomy 13 here. You see the heart shape is very globular, and you see the aorta is straight in front of the intervenous septum. Another example here. Now pay attention. What do you think about the AV valves here? Are they normal AV valve? No. This is a big intravenous septal defect. This is the complete form of intravenous septal defect. So here we have not only tetralogy of Fallot, but we have complete form, and you see the three-vessel view. The pulmonary is much thinner than the aorta. Another example here, much more subtle. You see there's a small subaortic VSD, not very big, but you see the leg of the ballerina here is broken also. The leg is not looking at the foot, the leg is looking at the intervenous septum. But you see this aorta here is normal size compared to the ventricle. Okay? When you see that, the next thing you want to look at is, do we see the pulmonary? And this baby, you don't see the pulmonary. If you have a doubt, you do Doppler, because if you don't see the pulmonary, it has changed name. It becomes pulmonary atresia with ventricular septal defect. Here, what do you think about the aortic valve? Is this aortic valve preventing regurgitation or not? Not at all. This aortic valve is just floating in the flow, just like a seaweed in the ocean. Okay, so this is an incompetent aortic valve. Four-chamber view looks pretty normal, just a small defect over here, and you see the ballerina leg here is abnormal. It has a kink at this level, and we have overriding of the aorta. Another example with a large aorta, you see again the aortic valve here is flopping in the flow, and the aorta is bigger than either the right or the left ventricle. So complete aortic insufficiency. Here, a four-chamber that looks pretty normal. The AV valves are at the same level, so this is worrisome. And when you see the aorta, there's a small defect here, much more. So you have a great variation in degree of tetralogy of Fallot. Here's another example where you can see the overriding and the aortic valve. And when you go to the three-vessel, same thing again. You have a large aorta and a thin pulmonary next to it. If you look at the Doppler in the pulmonary, you will have the use of Doppler to make sure that the pulmonary is patent and to assess the direction of the flow. You want to make sure that there's forward flow and not retrograde flow, and you want to make sure that it's not too fast, because that may be that the pulmonary valve is becoming atretic and you have turbulence in the pulmonary. For instance, here you have velocity at 180 centimeters per second. So this pulmonary valve is becoming very stenotic. Here's another one with 115 centimeters per second. So this pulmonary valve is also getting stenotic. Otherwise, when you look at Doppler, it's mostly to see the turbulence in the ascending aorta and look at the presence of the pulmonary underneath the aorta. Same thing over here with the turbulence in the ascending aorta due to the increased flow. The differential diagnosis here is pulmonary atresia with ventricular septal defect and the truncus arteriosus. So when you look for tetralogy of Fallot, what do you look for? First, you look for left axis deviation in the four-chamber, and you look for right descending aorta. So that's in the four-chamber. In the outflow tract, you look for an aorta that is overriding the septum by less than 50%. If it's more than 50%, you talk about double outlet right ventricle. You also want to make sure that the aortic valve is competent and not stenotic, and then you want to look at the pulmonary artery to make sure that it's patent and not retrograde flow. So let me show you the extreme form of tetralogy of Fallot, which is wrong, which is the absent pulmonary valve syndrome. So here what we have is the same findings. We have a ventricular septal defect, we have an overriding aorta, but instead of having a pulmonary artery which is too thin, we have a pulmonary artery which is much too large. And here the defect is the absence of the ductus arteriosus. So there is no communication between the pulmonary artery and the aortic arch. So they resemble each other, and this is called one of the form of deteriorative PHILLIP. So we don't have the ductus arteriosus, so the blood that enters into the pulmonary will have no choice but to come back into the right ventricle. And remember, regurgitation is what causes enlargement. There will be an annulus of the pulmonary which is very distended, but that prevents the normal development of the pulmonary valve. So when you look at the four-chamber, what do we see abnormal here? The right side of the heart is larger. There's a pericardial effusion. The apex of the heart could be shifted to the left side. It's not really in this case. And what else is abnormal? The descending aorta again. You see the descending aorta is on the right side of the spine instead of being on the left side. So big clue for coronary anomaly. And you can see the ventricular septal defect, but it's not always visible in the four-chamber view. So here we have the outflow tract, and you see the aorta is overriding both ventricle. You see the crest of the septal defect, this little white dot over here. And when you get into the outflow tract, here you have this very classical image. This is a massively distended pulmonary, and you see the left branch and the right branch over here, and the aorta is over here. So this is quite different, and sometimes it is so big that I've had babies that have been referred for lung cysts instead of for cardiac anomalies. And here you can see the main pulmonary. This is the right pulmonary, this is left pulmonary, and you see the pulmonary valve here, which, although it is called absent pulmonary valve, it is present, it's just completely incompetent and failed to develop properly. So this is an example. You see the four-chamber, you see the right outflow tract, and you see this massively distended pulmonary arteries branching into the lung. Doppler finding, well, you can anticipate what the Doppler sound is going to be. You will have forward flow and you will have regurgitation. So it's going to sound. It's a very classic sound when you look at that. Here you can see the regurgitation, and you can see the forward flow and the reverse flow. So remember this absent pulmonary valve syndrome. What you will see when you do the three-vessel view, you will see massively distended pulmonary. Okay, so I want you to quickly show you the persistent left superior cava, because I showed you many examples of that yesterday. This is the heart view from the back side, and originally you had a left superior cava, a right superior cava, you had the vitelline vein, the cardinal vein, and the umbilical vein, and they all merge here at the level of the heart into the inferior cava, and the right superior, the left superior cava progressively disappear and is connected to the right side by the innominate vein. That's what happens in the normal embryo. In babies that have a persistent left superior cava, then superior cava end up draining into the coronary sinus over here and connects in this way. So this innominate vein may or may not develop, and you have this long superior cava that is persisting over here. So if you look at the heart from the back, this is the normal one, this is a persistent left superior cava. You have a vena cava that is in front of the pulmonary and pulmonary vein and drains in the coronary sinus over here. If you make a section at the three-vessel view, you see the pulmonary vein, pulmonary artery, aorta, superior cava, and on the left side of the pulmonary artery, you see the persistent left superior cava. If you move your section and you go at the level of the four-chamber view, you see between the left ventricle and the left atrium, you see the pulmonary artery over here, the persistent left superior cava. Now, sometimes it can drain into the backside of the left atrium, and then this is all you can see. but you have to go down further, and instead of staying in the fourth chamber, you go all the way to the bottom to see the coronary sinus. And if you see the coronary sinus and it is distended, then you know that the persistent left superior cava is draining in the coronary sinus, and then you think about the heterotaxis syndrome, look them up, and if you don't see a heterotaxis syndrome, it's essentially a very benign anomaly. So here we have the fourth chamber, you see the persistent left superior cava at this level, and when we go a little lower, you can see the communication into the coronary sinus, into the right atrium, and when we go up, we're going to go into the three vessel view, and we're going to see it on the left side of the pulmonary. Very typical. Okay, so 95% of them drain into the coronary sinus. You'll have a big coronary sinus, 5% drain into the back of the left atrium. And then I wanted to show you some of the heterotaxy, because we mentioned that several times yesterday, and I don't have much time, so I may have to go fast here. So compared to the normal sinusitis baby with the apex of the heart and the stomach on the left side, you also have a mirror image baby, which is a sinus inversus, heart and stomach and spleen are on the right side. And then you have anomalies of sinus in which the heart and the stomach may not be on the same side. You may have the liver in the middle, and this is the one in which you think about the heterotaxia. Now, I'm going to skip the way to identify, but there's some way to recognize the right side from the left side. There's some organs typically on the right, some organs typically on the left side. Now, in sinus inversus, let me show you just some image. This is the typical image. You have apex of the heart and stomach that are both on the right side of the baby instead of being on the left side of the baby. So in heterotaxy and isomerism, what you have is an abnormal arrangement of organs or part of the body in relationship to each other. So if you have a right isomerism, you have right structures. So you will have a baby that has a normal right side, and on the left side, instead of having a left side, it has a mirror image of the right side onto the left side. Think of this as being a half sinus inversus attached to a normal baby. And if you have left isomerism, you will have left structure on the left side and mirror image of the left structure on the right side. And that's a very convenient way to think, because if you think that your baby has right isomerism, all the left-sided structure will be defective. If you have a baby that has left isomerism, all the right-sided structure will be defective. This used to be called asplenia and polysplenia in the old days when I was a medical student. So let's start with left isomerism. And here we have left-sided structure. So the IVC is a right-sided structure. So no right-sided structure, no IVC. You will have IVC interruption with azygous continuation. And you will have absence of the sinus node, and so you will also have slow heartbeat and influx. The anomalies include biventricular anomalies with ventroseptal defect, atrioventroseptal defect that we just discussed earlier, and the heart can be either on the right, in the middle, on the left, and AV blocks are common, so this baby have trouble when they're born. You can look at the atrial appendage. This, I have shown you this image, superior cava and no inferior cava, very classical. And the other very classical image is a section in the chest in which you see two vessels side by side. One of them is the azygous vein, and the other one is the descending aorta. Now, when you see the vessel like here, we have aorta, and here we have another vessel next to it, and that is not the vena cava, as I showed you yesterday. This is the azygous vein. The vena cava should be about at the level of the O in aorta here. Okay, so very different. And here, behind the fourth chamber, you see the aorta, and next to it, we don't have the IVC. The IVC should be draining into the right atrium. This is the azygous continuation in IVC interruption. And when you do heart Doppler in the chest, you see this classical image with the aorta and azygous next to each other. This one is red, so it's going towards the transducer. This is the aorta. This one is blue, is going away from the transducer. This is azygos, and that's how you can recognize one from the other. The baby will have bradycardia. The liver can be symmetrical. There can be some ascites. You see the umbilical vein is entering in a straight line instead of coming with a curve. And here you can see that the stomach can be either on the left side or on the right side. The stomach is not a reliable indicator. And you can see that this stomach here is not in the normal position. The stomach should be further away, not close to the spine, like in this image here. So here we have aorta and azygos vein next to each other. Baby can have polysplenia, but this is hard to see with ultrasound. And these are the important findings in that isomerism. So IVC interruption is really the one you want to be looking at. And then let me finish by showing you some clips. Here we have the two vessels into the chest and the two vessels side by side next to the spine. Very typical of IVC interruption. And when you do Doppler, you see this is the azygos arch. You see the blood is going from the back to the front. This is the azygos arch, the image I showed you yesterday. And you can see the two vessels inside the chest. Now, the right isomerism, you have baby that have two right sides. So the inferior cava, instead of being in the normal position, is going to be in front of the aorta on the same side as the aorta. This is very classical. If you find a juxtaposed aorta and IVC, this is a baby that has right isomerism. Well, what also goes on the left side? Pulmonary veins. If you don't see the pulmonary vein returning to the left atrium, suspect the baby has right isomerism, and the spleen can be absent. So here you see the midline section. We have the aorta and inferior cava in front of the aorta. Only right isomerism can give you that. Here again, the aorta, inferior cava, in front of the aorta and on the same side. Only right isomerism. So here we can see pulmonary veins that are not returning to the left atrium. They are going at the intersection between the right and the left. So anomalous pulmonary venous return. Or you can look for a vein that goes behind the heart and drains into the liver. And this is the barren connection between the pulmonary vein and the liver. And with Doppler, you can see the aorta going in this direction, you can see IVC going in that direction, and you can see this vein going from the chest into the liver from the anomalous pulmonary venous return. So here you can see aorta and cava is on the same side, and you see the stomach on the other side. You see that stomach is very abnormal, and the cava and aorta are on the same side. Another example with aorta and cava on the same side. Very typical of right isomerism. So for the isomerism, remember left side, you have two left-sided structures, so the right side structures are missing, IVC interruption, and for the right side isomerism, left side is missing, so the baby will have anomalous pulmonary venous return and will have IVC in front of the aorta. Okay, this was a lot of information, but I managed to get just in time for my talk. Thank you very much for your interest.
Thank you, Professor JEANTY, for